Welcome to the AUA News Inside Tract podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Hello, everyone, and welcome to today's podcast brought to you by the AUA Medical Student Membership Work Group. My name is Irene Choi, a research fellow at the University of Wisconsin School of Medicine and Public Health, Department of Urology, and fourth-year medical student at the St. George's University School of Medicine. I currently represent the Society of Women in Urology to the Medical Student Membership Work Group. Today's episode is part of the Urology Spotlight series, and in this interview, we will be discussing pediatric urology. I have here with me today two very special guests, Dr. Kristen Ebert and Dr. Casey Seidemann. Dr. Kristen Ebert is an assistant professor in the Department of Urology at the University of Wisconsin School of Medicine and Public Health and co-director of Simulation Education. She is also the director of Pediatric Spina Bifida and Transitional Urology programs at the University of Wisconsin. Dr. Ebert earned her medical degree from the University of Wisconsin School of Medicine and Public Health and the urology residency at The Ohio State University. She went on to complete a pediatric urology fellowship at Nationwide Children's Hospital in Columbus, Ohio. Dr. Ebert is an active member of the American Urological Association, the Society of Women in Urology, Sexual Medicine Society of North America, and Society for Pediatric Urology. Next, Dr. Casey Seidemann is an associate professor of urology at the Oregon Health and Science University School of Medicine. She earned her medical degree at the Albert Einstein College of Medicine and did urology residency at the University of Texas Southwestern Medical Center, followed by fellowship in pediatric urology at Cohen Children's Medical Center, Long Island Jewish Medical Center. Dr. Seidemann is an active member of the American Urological Association and the Society of Women in Urology. Welcome. Hello. Thank you guys for joining us today. So let's start with Dr. Ebert. What are some bread and butter cases in pediatric urology?
Yeah, I think I've heard like a running joke before that we do 5 cases in pediatric urology. So I think circumcisions obviously is the number one case that we do, or circumcision variations. Orchiopexies, so bringing down undescended testicles, as well as like hydrocele and hernia repairs. I think those are pretty common. And then some of the more bread and butter major cases that we do would be hypospadias repairs, pyeloplasties, and ureteral reimplantation. And then there's a lot more complex things that we do as well that I would probably say maybe fall outside the scope of bread and butter, but it's a fun specialty with a wide mix of cases.
I see. Dr. Seidemann, do you have anything else to add on to that?
I agree. Sometimes we joke around and we say that we do a lot of bats and balls. So penis surgery and testicle surgery, and that would comprise a lot of the bread and butter. But one of the reasons that I really love pediatric urology is that despite the fact that maybe the vast majority of our cases are bread and butter, it's really the wide variety of things that we treat and the complexity of cases that really make it exciting.
I see. Dr. Seidemann, is this a reason that you decided to pursue a fellowship in pediatric urology?
When I was a resident, I wanted to do everything. After I did robotics, I wanted to do a robotics fellowship. And after I did sexual medicine andrology, I wanted to do that fellowship. And it was really interesting because I felt very passionate about each of the different specialties. It wasn't until I did peds as a senior resident when I realized that pediatrics actually has a little bit of everything inside of it. So I get to do big open cases. I get to do robotics cases. I get to have one day of nice, easy, small cases. I get to treat patients with neurogenic bladder. And I think it was a combination of the variety of surgeries and the fact that kids tend to do really well. Kids have such a great attitude. They heal so much faster. They have fantastic outcomes. I think it's a combination of the variety of cool cases and just how awesome kids are in general that made me decide to do peds. But it took me a while to get there.
How about you, Dr. Ebert? What made you choose pediatrics?
I think I agree with Dr. Seidemann in that you get to be a specialist, but still a generalist at the same time. So I didn't want to just do robotic surgery. I didn't want to just do stone surgeries. So it's the opportunity to be fellowship trained, but really get to do a little bit of everything. That was part of it. And then I think the other thing that I really liked about pediatric urology was the anatomy during surgery. It's so beautiful. I love anatomy. And when you get to operate on a pediatric patient, you really get to see the structures in a way that you don't get to see in adults. Um, and then the last reason is kind of that opportunity for some of my patients to take care of them across their lifespan. So, you might do a prenatal consult on a mom with a fetus with spina bifida, and then have the opportunity to take care of that baby, throughout their life. So I think that's a really kind of special and unique opportunity.
How much of your time is spent in the clinic versus the OR, Dr. Ebert?
I think it depends a lot in, where you choose to practice, the mix that you get. For me, I would say right now I'm probably in clinic at least twice a week, sometimes 3 times, and in the OR at least once, if not twice. And then I also have some academic time. So my split right now is 80% clinical and 20% academic. So, but there's a lot of different ways that you can split your time, and some places might have you do more OR and less clinic. Some people choose a career with half of their time spent doing academics. There's a lot of opportunity for variety.
How about you, Dr. Seidemann, in your practice? What is your time split between clinic and OR?
Yeah, so I have about 2 days of OR every week and about 2 days of clinic every week. So I might be a true 50-50 in terms of my OR clinic split. And then I have 1 day a week for administrative and research purposes as well, which is actually the best day of the week, if you ask me. But I love my clinic days and I love my OR days, and I love having that kind of 50-50 split. I think it works out really well. It's a nice balance.
Yeah, and I think as far as specialties go, I think a lot of urologists enjoy, doing some clinic. That's part of the reason why we chose the specialty, was kind of the medical aspects of it. And I would say, um, for better or for worse, a lot of pediatric urology has transitioned to more medical management than surgical management. And so clinic is a big part of our practice.
I see. And how long do your cases go typically? Start with Dr. Seidemann.
Yeah. So I would say that it totally depends on what your day is like. I can have a day where I do 7 penoplasties or orchiopexy surgeries, and they're pretty quick. They maybe take 45 minutes, and if it's a good day, a 20-minute turnover. Or I could do one all-day reconstructive case that just really takes all day from 7:30 in the morning till 5 or 6 at night. And some of these complex reconstruction cases on kids with spina bifida can really be an all-day surgery. Um, I like the variety of that, and I think that that is a big draw, but it also makes it really hard to be predictable when it comes to your surgery scheduling. So oftentimes, usually I'll have 1 day of small cases and 1 day of bigger cases, and that's how I kind of off-put the emotional and physical burden.
How about you, Dr. Ebert? How long do your cases go typically?
Yeah, I echo what Dr. Seidemann said. My OR block time runs 7:30 to 5 o'clock, and it all depends on what I can fit in there. So, usually it seems like most of the time, it's a bunch of smaller cases, the bats and balls, that kind of all get put on one day, and then maybe you have a couple bigger cases, like maybe 2 robotic cases in a day, or ureteral reimplantation and maybe a few other cases to follow that, or hypospadias. And then, like Dr. Seidemann said, a big reconstruction with an augment and, a catheterizable channel could take all day. So I agree. I like it. I also agree that I couldn't do just reconstruction. There are some people out there who do that and, have these huge cases multiple times a week. But that does kind of get exhausting.
I see. And I understand that you guys are both in the academic world, but Dr. Ebert, you were previously a little bit in the private world. Am I correct?
Yes.
How was that different from the academic world?
Yeah, so, everybody's private experience is a little bit different. I wasn't true private practice. I was an employed practice, where I was the sole pediatric urologist for a rural health system in northern Wisconsin. So, I think there's pros and cons. I enjoyed certain aspects of my practice. I mean, as the only show in town, I really got to do everything, and there was nobody to compete for cases, and so there was kind of that opportunity to tailor my practice as well. So I got to see some adult patients with congenital conditions, and frankly, more OR time. I was probably in the OR 3 days a week in employed practice. But I think the nice thing about academics is having partners, the opportunity and ability to have ancillary support to take care of bigger cases, and just more nurses, for example, or having a scheduler to set up my meetings, that kind of thing. So I'm happy to be back in academics.
Dr. Seidemann, what made you choose to be in academics?
I would say the big draw for me was teaching. I've always been attracted to mentorship and teaching and those sorts of relationships. And I do know that there are places where you can be in private practice and do that. It just happened to be when I was looking for jobs, what was open and what teaching abilities there were. I love working with residents and medical students, especially teaching them in the operating room, and that was very important to me. I'm also fairly passionate about research, less so from a basic science perspective, more so from an patient outcomes perspective. Um, and I think that it was important to me to go to a place that supported all of my interests. And so there was something a little scary to me about maybe going into private practice at first, where I felt like the amount of money you make would be directly correlated to how many patients you see and how many patients you operate on. But I have a lot of friends who really like that direct correlation and find that it's a very sort of clear way of practicing and enjoy it very much. So I think it's sort of a little bit about knowing yourself and knowing what your passions are and what motivates you to work hard.
Yeah, my advice for, students considering this field is that you really can find the right mix in a practice if you're sort of willing to go anywhere. So it's sort of about what's important to you. Is it location? Is it teaching? Is it having time for research? Is it money? All of those things. So, and I will say that, I did take a pay cut coming back to the academic world. So, there is that kind of benefit from being in private practice, but I also really enjoy teaching too. And, now I have an opportunity to do research where before it was kind of on my own time and not paid. So,
So, on the topic of medical education, Dr. Ebert, what would you like medical students to know before they go on this journey of pursuing urology and then possibly pediatric urology?
um, I think if you're wanting to do urology, I think the biggest thing to know about it is it's very competitive. And so I think it's only getting more and more competitive. The earlier you know, the better, which can be tricky sometimes, but if you think you might have an interest, if your school has an interest group or something like that, where you can maybe go meet some urologists, get your hands on a cystoscope or, other things like that. It's a, it's something that knowing earlier is better. So, um, you want to get good board scores and you want to distinguish yourself with research is kind of, I would say, the number one thing that people are looking for on applications now. But other extracurricular activities are good as well. So they sort of want to see a really well-rounded applicant with good grades. So that's my advice.
Thank you. Dr. Seidemann, do you have input?
Yeah, I echo everything that Dr. Ebert just said. And every time I go through applications, I'm always like, wow, how did I match into urology? Everyone's amazing. But I would also say don't be overwhelmed by that. I think that there are a lot of people who may not think that urology is for them, or they sort of brush it off, or they don't even really know what urology is, right? Because it's kind of a little bit of a secret field in many ways. I would say just explore it. See what speaks to you. Spend as much time as you can shadowing and getting to know what life is like, including and most importantly, probably the residents, because that's, I think, a really integral part is to see what residency is like. And if you think that that's for you, it is a surgical field. And I think exploring what that means for you as a medical student is really important and seeing if you feel energized by being in the OR and getting to operate, or if you feel kind of like that's not right, this is a really great early opportunity for you to explore that. I would also say find good mentors. A good mentor in urology is probably one of the most important factors for success because mentors are the folks who put your name out there for opportunities and help connect you across the country. And urology is actually a pretty small field. We all kind of know each other, especially pediatric urology. So mentorship, 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 and then experience, kind of get yourself out there, see what it's all about, make sure you really like it, and then you can focus on the stuff that's important, like research and away rotations and performance and board scores.
Yeah, I would say don't be afraid to put yourself out there. I think that was something that was hard for me, especially as a student, and even still can be early in my career, approaching somebody who's above you. But just be yourself and be enthusiastic. And, if you think that there's somebody that you might have a connection with, ask to meet with them and, have an agenda of something you're hoping to get out of that meeting. And I think most of us would respond to that pretty well.
Okay, thank you. And on the topic of research, Dr. Seidemann, what are some current trends or exciting recent developments within pediatric urology?
One thing that I think is really interesting, and I'm looking forward to kind of seeing what happens in the future, are concepts surrounding artificial intelligence and pediatric urology. AI is, really new in terms of its applicability to urology and medicine. I think that there's going to be a boom in the next, year plus to really understanding its limitations or what its potential uses could be. I see a lot of potential, not just in the realm of patient care, but actually in the realm of sort of physician help. So things like AI note writing tools or AI scheduling or AI email management. And so a big topic that I hear a lot about surrounds things like physician workforce burnout or attrition rates. And so I'm kind of excited to see where AI goes. And that's what I'm most looking forward to right now.
Have you started implementing AI in your daily life, Dr. Seidemann?
I have been experimenting a little bit with AI note writing. I'm actually waiting for our institution to go live with it, but a lot of institutions have started to integrate that into their practice. And I've actually looked at AI and the utility of it for things like patient education. And I will tell you that the jury is still out. I actually don't think that it's ready for prime time yet, but I see so much like change and growth by the month that I can't imagine that it's far away.
Yeah, I agree with Dr. Seidemann. AI is a big one. When I review for journals, I feel like there's new things about the quality of patient education that's out there that's being generated by AI, or AI for looking at things like hydronephrosis, which as you're doing a research project with us on that. So um, obviously the literature that I keep up with the most is, of my own interest. So transitional care, I think, is a hot topic right now in the field of urology in general as our patients with congenital conditions age. So a lot of research that's coming out right now on gaps in transitional care around the country and what we can be doing better. And a lot of it is single institution at this point, but my hope is that, the Society for Pediatric Urology and the AUA will kind of come together and hopefully work to create evidence-based models for transitional care. So that's my hope and my interest for my career anyway.
Dr. Seidemann, what is a case that gets you going in the morning? Like you see it on your OR list and you're like, that's it. Today's my day.
That is a trick question. I love all of my OR days. I would say that there's two different types of excitement for surgery for me. Type 1 excitement is where I just know that it's going to be a relatively straightforward day and I can achieve what I would call like a surgical flow state. And to me, a flow state is very enjoyable where I know the movements. I don't have to talk too much to the residents because they know the movements. The scrub tech knows the movements, and you can just sort of operate in this smooth, like dance-like state. And those days are wildly enjoyable. When they go well, you kind of end your day feeling like that was very satisfying. The type 2 enjoyable day is a really complicated case that I've worked really hard to prepare for. And it's more like a nervous excitement because you never know what to expect going in. But just like we tell medical students and residents to prepare, I prepare for all of my difficult cases. And to me, that looks like watching surgical videos, reviewing my own personal notes and images. Sometimes I will just try to visualize the surgery in my head the day before, write down the operative note in advance so that I'm prepared for all of the things that I need, meet with the scrub tech. And to me, that almost feels like game day or like the Olympic performance. So that's also very enjoyable, but in a completely different kind of way.
How about you, Dr. Ebert?
I was just gonna say that, like, I feel that day is more enjoyable at the end, like when everything goes well, but beforehand it's like super stressful. So I do all the same things that Dr. Seidemann does before a big case, especially if it's not one that I don't do that often. Like I did a robotic bladder augmentation, maybe 6 months ago or something like that, and I hadn't done one for a while, and so it was like, okay, I got to go look back through all my notes through fellowship and review my operative report, and so that was a day that I was happy with how it went at the end of the day. So, but a case like that I really enjoy doing. I really enjoy open pyeloplasties. I enjoy open ureteral reimplantations. They're kind of like um, a fairly routine case, I would say, at least when there's straightforward anatomy. But it's not so simple like a circumcision or an archaeopexy that it feels boring. But it's always really nice anatomy, nice steps, nice length of a case. Those were the two cases that made me kind of want to be a pediatric urologist. So I always like those on my schedule.
I know that we mentioned residents briefly. How often do you interact with residents, Dr. Ebert?
Um, Certainly I have a resident for all of my OR days. I wish that we had more residents on rotation with us and they could come to clinic a little bit more just because there's a lot of learning that happens there. I feel like that's the eternal struggle of the attending, right? I always want the resident in clinic, but we just have one resident on service with us. And so with 4 faculty, they're usually in the operating room. But then we also see them at our teaching conferences. Sometimes I have one in my clinic. Sometimes they come to sedation unit cases. So at least a couple times a week, I'm working with the resident, and I do really enjoy it. When I was in employed practice, I had medical students that worked with me, and then occasionally we had a general surgery resident. And I like kind of the continuity of having the same urology resident, for 6-8 weeks.
How about you, Dr. Seidemann in Oregon?
Yeah, I would say that I have a resident with me most days that I'm clinical. We have 2 residents on our service for pediatric urology. And so usually if I'm in the OR, I'll have a resident. And in clinic, I'll have a resident, or at least part of the time, or I'll see them, or I'm on call spending time with the resident. I feel like we spend a lot of time together, and I really enjoy that relationship. It's sort of like a mini fellowship. And since we don't have fellows, and I know at Wisconsin you don't have fellows as well, it's a really great experience for the residents because they get to do things that I think fellows would get to do if they were in a program where there were fellows, if that makes sense.
Definitely, for sure. I mean, occasionally we'll get the chief resident come if we're doing a bigger case, to work with the two. But it's a real pleasure and joy to watch the second year residents like grow throughout the year because most of them come in, fairly green in terms of their surgical skills, and you really get to see them kind of blossom with that by the end. It's really nice.
So in a way, it's a nice blessing that the two institutions don't have pediatric fellowships.
I think our residents would say so.
Yeah, I think there's pros and cons. I was a resident at a place that had fellows. So I think there's a lot of opportunities as a junior resident to work with the fellow, which is a really different experience from scrubbing with the attending. So I think it can be really cool. And then the other thing about a fellowship program is inherently it's going to attract the really complex cases. And so that's also pretty cool to see as a resident. So yeah, pros and cons.
So we're talking about fellows now. What does pediatric fellowship look like, Dr. Seidemann?
So pediatric urology fellowship, it's required to be at least 2 years. 1 year has to be clinical, and 1 year is sort of flexible in terms of developing a research or academic mission. Every program is a little bit different, but typically you have a very intense and immersive experience for your clinical time. So you are taking call, learning what life is like as an attending pediatric urologist, trying to scrub all of the big cases. So typically when you do a fellowship, you have a lot of different cases going on. So you kind of have to choose what you need to experience or where your experience level is at that matches your desire. Um, it's pretty intense, I think, but it's really worth it because if you think about it, it's kind of wild that you can fit so much into one crammed clinical year and then kind of go out into practice. I was fortunate in my fellowship that during my academic year, which was my second year, I was also able to be a junior attending. And that was really valuable for me. That's where I learned how to take, brand new junior residents through cases on my own. And, there's a little bit of a struggle there, but I was very appreciative for that because I knew that I had backup and that served me very well.
Yeah, it's a shame now that they've taken that opportunity away, I think, because now both years of the fellowship are run by the ACGME. And so that means as an ACGME fellow, you are not allowed to have attending privileges. I also had that pre-tending year during my second year, and I think it's super valuable in terms of setting up the cases. Sometimes I would only have a scrub tech in me to do a case, because we just had one resident. And so learning how to troubleshoot that or walk somebody who really has no experience at all, through assisting you is really helpful. I think the one nice thing about going to an ACGME for both years, at least from what I've heard, is kind of that opportunity that if you don't feel quite ready at the end of that first year, if your first year was clinical, to kind of have a little bit more time to do some clinical work. So places are structuring their fellowship different kind of around the country now in response to this. So I think from what I've heard from some other fellows is they kind of like that opportunity to have a little bit more time because there is a lot to fit in a single year.
So, on-call schedules. What does a typical on-call schedule look like for the academic pediatric urologist? Let's start with Dr. Ebert.
Yeah, so I mean, it depends on how many partners you have. Obviously, and every academic practice is not all created equal. I have 3 other partners, so I'm on call 1 and 4. I'd say the average academic practice is probably between 3 and 6 urologists. There are some that are bigger than that, some that are maybe smaller, but a lot of places I know will take call a week at a time. Other places might, trade weeknight calls and then just have like the weekend as a block. Another model that I've also seen is actually being part of the adult call pool. So, basically peds and adult urology is all in a single call pool. So you're taking call less often, but when you are on call, you have to take care of all the adult patients too. So pros and cons. I think call can be really hit or miss for me. There are some weeks where I don't sleep through the night any night. And there are some nights where, I might sleep every single night. And I would say the average week maybe has 1 or 2 operative cases that I'm going for like off hours, usually some calls from the residents at night, some calls from the transfer center, about patient questions or people wanting to transfer in patients. So it's not horrible. Can be tiring, but it sort of depends on the week.
Dr. Sideman, do you have any input?
Yeah, where I work, there are 4 of us, soon to be 5. So we take call currently Q4. I take every Monday. So Monday's my weekday, and then we sort of alternate Friday through Sunday. We actually changed. We used to be 1 week at a time, but we just became so busy that those weeks became impossible to actually get any other clinical work done in a meaningful way. So our calls are fairly busy. We do service like the entire state of Oregon and some neighboring areas as well. So we find that we get a lot of phone calls just from other hospitals trying to get help managing their patients. So for me, that's probably the greatest burden. We do occasionally have to go in and operate. There might be a kid that can't get their catheter in their catheterizable channel. There might be a testicular torsion. There might be, an emergency circumcision for a kid that can't pee. I would say that it's sort of a nice variety on call, which is nice, but it can be very busy and that can be challenging. I think that that's an important thing to understand going into pediatric urology because oftentimes our groups are smaller than our adult cohorts. And so when you are looking for a job and you have to think about call considerations, you need to consider what you're capable of doing in terms of call coverage.
And that was part of my reason for leaving my last group was that there were only 3 of us, and my other partners were more seniors. They had a lot more vacation time, and so there was quite often, times that I would be on call every other day. And since I was doing adult and peds call, it was very exhausting. So yeah, call is a huge part of what we do. And I think there's sometimes a misconception for people thinking that, oh, there's not emergencies in urology. There's actually a lot of emergencies in urology. Even if not all of them are operative, we get a lot of consults. It's quite busy. Both peds and especially on the adult side. So just something to consider if you're a student thinking about the field. We're definitely a true surgical subspecialty.
We kind of mentioned how you guys cover both the adult side and the pediatric side at times. And I understand that you guys are both in pediatric urology, you're double board certified in general urology and in pediatric urology. How often do you guys see general urology, adult urology? Dr. Seidemann?
So I no longer see any general adult urology in my practice. The adults that I see are congenital adults who have pediatric urology problems, but then just became older than 18. So anyone who is over the age of 18 and doesn't have a congenital pediatric urology sort of pathology or diagnosis goes to the adult side. Occasionally they try to get, a kid in through the emergency room that might be, or I would say kid, but an adult or like a 19-year-old with a trauma or a stone, just because sometimes we're the path of least resistance or we might not be as busy as the adult emergency room. But for the most part, we have a pretty hard stop at 18 for general urology type of conditions. I think it's different. It just depends on where you choose to practice. We do not cover the adult side, so they have their own call coverage. So we only cover pediatric urology, and the only true overlap are going to be those adults that have congenital issues.
How about you, Dr. Ebert?
Yeah, I think, I've practiced in both worlds. So, when I was in a private, non-academic setting, it was me and 2 other partners, and we took all of the calls when we were on call. So my clinic outpatient practice was primarily pediatrics, but, when somebody came in with hematuria or an obstructing stone on call, I took care of those patients. And I think if you like adult urology, it can add a nice mix, to your practice. I enjoyed sometimes adding on a stone or a TURBT at the end of my day. But I also have friends that are like, oh God, adult urology, like no way. So, right now in my own practice, I do not do any adult general urology. I do run our transitional urology program. And so I do see adults with spina bifida and congenital conditions. And occasionally we'll have a patient come to the emergency room who's maybe 30 years old and hasn't been seen by urology for 10 years. And, they'll get referred to my clinic as an outpatient.
Is there anything else you'd like to share with your audience before we close, Dr. Seidemann?
Just that I think pediatric urology is a really amazing field, and there's definitely a huge need for more pediatric urologists out there. We have a ton of patients. We have a ton of places that are constantly looking for pediatric urologists. So if you think that you're interested in pediatric urology, I would highly encourage you to spend some time or reach out for mentorship or shadowing experience to see if that speaks to you. And, just keep your mind open. It's a wonderful field with really awesome people.
Dr. Ebert?
Yeah, I think the one thing we didn't really hit on at all was kind of the parent factor that a lot of people are scared of. So, um, it's not for everybody. I really enjoy working with uh, families, and I enjoy seeing a kid on my exam table. And I think it adds an extra layer of challenge that sometimes your patient can't really tell you what's going on, that you just have kind of a secondhand view from the parent about what's going on. So there's a little bit more of sometimes a diagnostic challenge or mystery that comes with it. But, I thought parents working with them would be hard. And then I became a parent myself, and it was kind of easier to understand, exactly what parents are going through. And it's a really special relationship when a parent gives you, entrusts you with the care of their child. So, and when you come out after surgery, I mean, these families are so grateful. So, I enjoy that aspect of it a lot. So don't let the fear factor of the parents turn you off.
I agree. Parents aren't scary. You just need to learn how to communicate with them. They're looking for reassurance, and that's, what we're there to provide. Also, there's an element of, children are blameless. They're just born into their own circumstances, and they're not responsible for the things that are happening to them. And so for me, it's really easy to be incredibly empathetic towards pediatric patients. And that really helps when you're very busy, on call, have emergencies coming in. It's very important to kind of reframe and remember why you do what you do.
Thank you so much, Dr. Ebert, Dr. Seidemann. Thank you so much. I want to thank you for your time and sharing your expertise with us. I think your insights will benefit many medical students potentially interested in pursuing a career in pediatric urology. I'd also like to thank our audience for listening. We hope you enjoyed today's interview, and that we'll catch you again on the next episode of the Urology Spotlight series.
This has been an AUA News Inside Tract podcast. To hear more episodes of this podcast, visit www.auanet.org/podcast.